Okay, so good afternoon. Welcome to this very last TNT of the day. So it's good to see that the room is pretty well filled. So thank you for your attendance and your dedication to try and to learn all together about this that platform, the Accurate Neo 2. And so we have a couple of objectives that we will try to address today. So the idea is to all together to try to understand the impact of some complications that we try to avoid at the index procedure: paravalvular regurgitation, conduction disturbances, stroke, permanent pacemaker after TAVI. To understand how the transcatheter heart valve design and its implication may have an impact on the first valve choice, once again at the index procedure. And we will try to discuss the latest clinical evidence in transcatheter heart valve. So I'm with Mohammed Abdel Wahab, that you all know, who's going to moderate the session with me. And we are a group of friends, and we are all here to learn together. So Julia Mashabauer is with us. We have Federico Di Marco and Christopher Cook with us as well. Mohammed, maybe we need to refresh about the way we can integrate the questions from the audience.
Yes, so probably you're experts now in interaction after a couple of days in London. So please interact either using your app or coming up to the microphones, ask us our questions. We'll be happy to integrate and discuss with all of you. So this should be like an open forum for discussion rather than us telling you what you should be doing.
Okay, so let's kick off the discussion. So it's going to be a lot about discussing about our daily practice. What are the challenges that we all face, and what we can improve, and how it impacts our device choice selection during the procedure. And I was maybe I'm going to start. Let's start with you, Julia. So what are the couple of considerations that you keep in mind, that you consider when it comes to selecting the device for your patient? Let's say that we are all talking about these younger patients. Rather than younger patients, I said potentially we should talk about patients with longer life expectancy. So you have a patient with longer life expectancy. What do you consider to optimize for the immediate result optimization after TAVI? What are the key elements that you consider?
For young patients, of course, I do not want to see stroke during the procedure.
Yeah.
Stroke is something I want to exclude. I would like to implant a valve with a large effective orifice size. So I would try to avoid putting in too small valves. And of course, I don't want to put in a permanent pacemaker. In addition, of course, the durability issue is something we have to bear in mind. And this would be my main, and coronary access.
Coronary access. So it's quite demanding in terms of.
There are many things.
So you would try to select a device with quite a nice durability, nice hemodynamics with large EOAs, low gradients, low pacemaker rates, stroke. You mentioned stroke.
Yes.
As well as coronary access as well. So it's kind of a lot.
I would think about the second device when I've put in the first in a young patient.
I think what's important really is that when we're thinking about patients with a long life expectancy, of course, what comes in mind that we want a valve that has a good durability, perfect hemodynamic function, valve that allows coronary access and is retreatable. All these are long-term considerations, but it all starts with a successful procedure, and this is something that we shouldn't compromise. So it doesn't help if you implant a valve that has a great durability, but the valve is leaking, for example. So, and this is why I'm bringing up this slide about paravalvular regurgitation, which I think it was the Achilles heel of TAVI in the early days. Now we more or less we forgot a little bit about it. And when it comes to younger, lower-risk patients, we really need to try and achieve results that are as perfect as surgery, because this is the alternative mode of therapy that these patients can get with more or less excellent results. So on this slide, you can see that there are some emerging data looking at long-term follow-up of patients with even milder forms of paravalvular leakage. And it seems that what we thought of initially, that mild paravalvular leakage is acceptable, that it seems to be a gradient. Like it's not only that more than mild forms of regurgitation affect prognosis, but even mild forms may affect prognosis. And when it comes to patient selection, this is what you see on the right-hand side of the slide. There are probably patients that we should think twice before engaging on an anatomy that appears to be complex, where regurgitation may happen, if we have alternatives. With the most fancy technologies we have, we still have anatomies where we may be thinking twice whether we should offer patients a transcatheter procedure or not. Assessment of paravalvular leakage is also a challenge, Chris. How do you do this in your practice? You just rely on the angiogram?
It's both for us, actually. But your key question is the first bit, is that it is very subjective, and it is a very variable assessment. And of course, actually, we're probably a little bit biased in the lab, aren't we? Because we will be influenced by the anatomy, the risk of post-dilatation, all these things. So I think what's important with this type of research is it's, core lab analysis is where you really get the assessment. But in terms of the clinical practice that we do have transthoracic echo in the lab, and we also combine that with the aortogram at the end.
Which, in my opinion, makes a lot of sense, because ultimately that's what we're going to follow up the patient with. It's transthoracic echo. So we probably, makes a lot of sense to assess his final PVL with that technique.
I have let's remain a couple of minutes on the PV leak equation. We all try to achieve zero PV leak. The patient leaves the cath lab, the hybrid OR, the surgical OR with no PV leak. But let's imagine that despite all our efforts, there is still a remaining regurgitation. To which extent are you going to accept it? And does the baseline PV leak impact your strategy? If the patient has moderate PV leak at baseline, does it change something? Federico?
Well, that should be, a sort of a mitigating factor in the future effect, in the future impact of a PV leak for the patient. So I would be, as you said, considering those factors which would, maybe prevent you from doing aggressive post-dilatation. We see annular calcifications over there. Those factors can be included in your algorithm inside the cath lab. And so, in my opinion, I think that having a baseline moderate regurgitation makes me more prone to avoid excessive maneuvers to get rid of a PV leak in the presence of some limiting factors.
And what about you guys? Is PV leak still a concern in your daily practice? Raise your hand. So not really. So it means it tells us that the devices that we are dealing with today are quite efficient in decreasing the PV leak rate. So that's reassuring.
The second topic that has been mentioned is patient prosthesis mismatch. You want to comment on that?
Yeah, we know patient prosthesis mismatch for a long time from surgical series, and we know that it very negatively impacts patient outcomes in these surgical patients. And there are a few data on PPM in TAVI. This is one example, a very recent example. Those papers basically all show the same. And this is a registry data from over 600 patients with small aortic annuli. And what you can see is that in the left panel, that patients that end up with less than moderate patient prosthesis mismatch have in 2/3 been treated with supraannular devices, whereas those patients that end up with moderate or severe PPR, patient prosthesis mismatch, those have been treated with more intraannular TAVI prosthesis. And when it comes to the size effect, you have to acknowledge that severe patient prosthesis mismatch has become a very, very rare event in TAVI. You can see the numbers at risk on the bottom of this Kaplan-Meier analysis. So severe PPM among over 600 patients was only the case in 38, which is around 5 to 6%. So very few patients in small annuli patients experienced severe PPM. And those had a trend towards a worse survival, as we can see from this Kaplan-Meier analysis. So the problem has decreased in magnitude, but it may be still there. And as we're treating more and more patients with our TAVI devices, we still should think at least a little bit about these hemodynamic features of our devices.
And so this could even be more relevant for small annuli, as you mentioned, that self-expanding supraannular feature. So that's a very important comment.
Yes. So I mean, we want a valve that seals. We want a valve that has a good effective orifice area. We also want a valve that avoids conduction abnormalities. I mean, the list of wishes we have is long, and the ideal thing would be to have a platform that combines all of these things. Why do we want to have a valve that doesn't cause a lot of conduction disturbances? First of all, we are comparing ourselves with surgeons, and we know that with surgery you have single-digit pacemaker rate, so this is one thing. The second thing, what we are learning now, and the data in this context are accumulating, that new conduction abnormalities may adversely affect prognosis. So this is a large meta-analysis, I think, of several thousand patients, and you can see here the bad prognostic impact of even persistent left bundle branch block on mortality, on heart failure, hospitalization, and also the impact of permanent pacing on outcomes. There are a lot, and you can see on the right-hand side of the slide, I think this is one of the topics that has been most extensively covered by publications, prediction of conduction abnormalities after TAVI. From the early days up till now, we have a list of predictors that is extensive. Probably some of these predictors are extremely strong, such as baseline conduction abnormalities. If you have a patient with a baseline right bundle branch block, this is the patient where you expect the most frequent rates of permanent pacing afterwards. But one of the important factors is also valve choice, Didier, correct?
Clearly, but it's when you talk about valve choice, you oppose the balloon expandable platforms to the self-expanding. So that's the general consideration that we have. Maybe we could have a little bit of granularity, because when it comes to self-expanding platforms, the technique that we use may have an impact on the final pacemaker rate, but the intrinsic features of the device, the way it deploys, may have also an impact. And I have to say that I've been impressed by that platform, the Neo 2 platform, that achieves quite low rate of pacemakers. And I was in the, I did a case of bicuspid patient with a right branch block at baseline, and with no conduction disturbance at the end. And we know that RBBB is a strong predictor of conduction disturbance. So the platform itself, to my opinion, have an impact, and most importantly, the way it deploys has an impact on the occurrence of conduction abnormalities.
Yeah, and even more importantly, with this platform, you can implant very deeply and keep the coronaries open and still have no conduction disturbance. You even should implant deep. And that's something that I find particularly...
Why do you think, Chris, it's like that? That it seems that the depth of implantation, which is something that is a predictor of permanent pacing across various platforms, doesn't play a big role with the accurate device. Why do you think this is true?
Yeah, it's a good question. And to be honest with you, I don't know exactly what the reason is, but it's definitely true. It is a phenomenon of this valve. You implant deeply by design and by choice, and you do not have that trade-off with pacing. I think it's largely probably due to the opening force of the valve is less than other self-expanding platforms. And particularly if you're talking about the Evolute, when you're unsheathing that valve, the actual opening force is actually very large and potential interaction with the bundle in that way. So you don't get that with the accurate platform. So I think that's probably one of the reasons why we do enjoy these lower pacemaker rates.
Would be interesting, of course, if we have a platform that also doesn't cause stroke.
Yeah, stroke is something we want to avoid by all means. And until recently, we had only one device to protect our patients, and that is the Sentinel device that has the advantage that it can be inserted easily, but the disadvantage that it leaves out the left vertebral artery. So this stays unprotected, and many centers have started to use it, but until recently we had no randomized trial, and the first trial was the protected TAVI trial. As many of you will know, more than 3,000 patients included in many centers in the US and in Europe, and this unfortunately, it came out neutral. So we had no clear benefit. We have not seen a clear benefit from this trial, although disabling stroke could be prevented much more often in the patients that were instrumented with the Sentinel device. So this is still an open issue where we have no real means and don't know how to treat our patients. Many centers have started because of these results. Others have stopped who first used Sentinel in every patient. So we are waiting for the BHF data, but in certain patients we will still use it. Patients with a previous stroke or with a lot of calcium, with bicuspids, with valve-in-valve procedures where we don't know, but we think this has a big advantage.
And Julia, how much do you think stroke is platform-specific, device-specific, instead of, patient and procedure-specific?
Well, I tend to think that a lot of unsheathing and resheathing is probably not ideal, but this is mechanistic thinking. I have the impression that speed is your friend. Those operators that do the procedure in a very short time, I have the impression this prevents stroke. I wanted to really analyze that, the relationship between speed of the procedure and the incidence, but yeah, we don't have these data yet.
Yeah, it's difficult to capture. Okay, so this was a very intense discussion. So we know now what is our wish list for patients with longer life expectancy. Federico, do you want to drive us through a kind of summary and how the TAVI platform could play an impact?
Absolutely. So we know that TAVI numbers are increasing. The total number of TAVI has surpassed that of aortic valve replacement in the US, so patients are living longer. So we already had our wish list. We do not need to think only about acute outcomes, procedural success, PVL, low gradients, and permanent PM, but we need to see to what's going to happen more down the road to our patient, future coronary access, commissural alignment, durability, and the possibility of TAVI in TAV are things that need to be included in the design of the platforms that we use today. The Accurate Neo2 as a worker device is a good device. This is data which has been presented earlier today by Dr. Kim about the real-world use of the Accurate Neo2 device. You see across different operative risks for patients. And at 1 year follow-up, we have some very encouraging safety data. Less than 1% mortality at 30 days and 5.1% at 1 year. And as we were discussing before, in real-world use, the Accurate Neo can deliver single-digit permanent pacemaker data at 1 year, 7.8%. This is coupled with a good valve device function. 84% of patients at the 1 year echo follow-up had grade none or trace paravalvular regurgitation, and less than 1% had the moderate paravalvular regurgitation. Valve function is good. You were discussing about large EOAs. We have 1.7 square centimeters and 7.6 millimeters of mercury in terms of gradient at 1 year. We were seeing the performance of different devices across small annuli. Small annuli are commonly encountered in clinical practice. 13% of patients have less than 400 square millimeters. And again, it's important to have, a device, mostly self-expanding devices in these anatomies behave pretty well, that does not give a severe patient prosthesis mismatch to our patient, because that's going to have an impact on future outcomes. This is a striking case, a dwarf less than 1 meter tall. She had a previous aortic valve replacement with an Elan 19, the true idea of the device being 12 by 15 millimeters. We implanted an Accurate Neo, and at 3 years follow-up, the device was performing well. You see the aortic root is pretty large, so that's why we were able to accommodate this device. And the device has 5 millimeters gradient at follow-up. So definitely good performance in terms of gradient for the Accurate Neo device. Also, we know that permanent pacemaker can have a worse impact in patients with low baseline ejection fraction. So this is another subset of patients where I might want to favor, the Accurate Neo device. We know, again, we've seen before that baseline RBBB is a strong predictor of permanent pacemaker. There has been an interesting German multi-center registry assessing the performance of different TAVI devices in patients with pre-existing RBBB. And what you see is that the Accurate Neo, as compared to the SAPIEN 3, is able to deliver lower permanent pacemaker rates in this very high-risk subset of patients. Coronary artery disease, this is an issue. In even low-risk patients on the far right of the screen have 20 to 25% incidence of coronary artery disease, and these patients are very likely to need a future heart catheterization. I see my friend Marco Barbanti, who published this data in the room. The REACCESS study, it has been shown previously that it's much easier with the Accurate Neo device to reaccess the coronary of a patient. This data has been presented earlier today, the REACCESS 2 devices, factoring in also the commissural alignment technique and the cusp overlap for the evolutes, but still the Accurate remains a device through which is easy to get access to the coronary. Commissural alignment, data from Chris Meduri in the US showing that it's fast to get commissural alignment, less than 2 minutes, and it's effective with the Accurate Neo. In 97% of cases, you end up with no significant misalignment. And also, Ole de Becker has shown us that this might have a future impact on outcomes. Patients having severe misalignment had a higher incidence of severe patient prosthesis mismatch as compared to the patients where the device was aligned, and they also ended up having more aortic regurgitation. So aligning probably matters for future outcomes. REACCESS, again, it's easy to think that when you have a double layer of struts in an evolute device which is misaligned, the residual strut to access your coronary can be very small, whereas having wide arches and wide cells makes it easier for future reaccess after TAVI in TAVI. And the last couple of slides I want to share with you is about a TAVI in TAVI case. We had a patient with an accurate neo who developed endocarditis, so his accurate neo became regurgitant. And you see how this represented a problem for coronary occlusion. If you implant a device here which is going to hold the leaflets in an open position, then you might have really an issue with your coronary perfusion of your patient. So this was done a few years ago. For at that time, the shortest device was a balloon expandable MyVal device, which we implanted very deep. And you see how coronary access, even after TAVI in TAVI, could have been prevented. We obviously accepted the leaflet, total leaflet overhang for this case, as it is clearly shown with a follow-up echo. We have an in-series leaflets, and also at the 4D CT scan you see that we have the two leaflets in series. So again, TAVI in TAVI is something we can easily do after the accurate neo device. And I thank you for your attention.
So thank you very much, Federico. So I guess we're going to move forward directly to you, Chris, for the case presentation, because you have a case of accurate neo 2 just to share with us. So let's see what is the clinical presentation of your patient.
Okay, thanks, Didier. So look, it's really important that we meet our patient now. So this is a 79-year-old female. I think it's relevant to state that she's of short stature, so she measures 155 centimeters only. She's diabetic, high blood pressure, atrial fibrillation, and a degree of renal impairment also. And her presentation is one of NYHA class 3 shortness of breath and a recent hospital admission for decompensated heart failure. Now, with regards to her echo, you can see that actually her ejection fraction is preserved, somewhat borderline gradients with a peak of 59 and a mean of 39, but an indexed aortic valve area of 0.48. Of relevance, she also has moderate tricuspid regurgitation and elevated right-sided pressures, but with no evidence of intrinsic lung disease or thromboembolism. Her ECG is not too bad, but it's also not quite normal, so she has sinus rhythm, a prolonged PR interval, and an incomplete right bundle branch pattern. So, now let's have a think about her CT scanning and the importance of the planning. So we can see already that this area here, highlighted in red, is small, 312 millimeters with a perimeter of 65. And we looked at some of the research previously where we stated less than 400 was considered small. Now, as we scroll down into the left ventricular outflow tract, we can see that things get slightly worse. Here now we're sub 300 with an area of 283 and a perimeter of just 62. And so what we can get from this two simple images is that we're dealing with small, if not tiny, annulus, which indeed funnels down into the left ventricular outflow tract. And here we simulate what a 20 millimeter balloon expandable valve would look like. And of course, the threshold to implant such a small balloon expandable device is paramount. Now, let's turn our attention to the coronary height. So as one might expect with a small stature patient and small anatomy, the left main stem is borderline at 8.4 millimeters. On the right-hand side, less of an issue at 15 plus. We then look at the sinuses, and again, we're dealing with small anatomy here as part of the entire case. And relevant to these types of decisions around revalving is that the STJ height here is just 15 millimeters. So let's look at the calcium scoring, and you can see that there's distribution there across all of the leaflets. But overall, actually, the calcium score here is not excessively elevated at 1,200. Now let's look at the access, and again, we're not seeing any particular red flags here. We've got low bifurcations on both sides. There's no excessive calcification or tortuosity. And with all CT analyses, it's always worth having a look up at the neck, thinking about things such as cerebral embolic protection, to which this patient will be recruited to BHF Protect. So again, we're seeing things in green here. There's no real concerns here with regards to access. I always tend, just before I start the case, to look at the plain anatomy again. And I think what's highlighting here is that we have good anatomy for embolic protection. But also, if you look here, it focuses the mind that this actual distance here is sub 6 centimeters. So what we need around the arch level is something that's truly deliverable and indeed flexible. So, summary considerations. Now, of course, we've been splitting this session into the immediate strive for perfection, but also making sure that we have a platform that gives us long-term options. So from the immediate side of things, we need to make sure that we do not experience coronary occlusion, that we avoid patient prosthesis mismatch, high-degree AV block, and paravalvular leak. And we want a device that allows us to commissurally align, and that's highly deliverable. And so with that in mind, this is a potential treatment strategy for us, with an accurate neo2 small, intentionally implanted at the target depth of 5 to 7 millimeters with commissural alignment. And that would tick all of those boxes and needs that we've been talking about during this session. With regards to long-term, well, of course, we demand durability, and we also have a need for coronary reaccess and revalving despite this very small anatomy. And again, our strategy here, should the event arise, would be to have a 20 millimeter balloon expandable aligned at the top of the frame. So Didier, that's the introduction.
Thank you very much, Chris. Maybe we have a couple of minutes just to discuss this patient. So, Julia, you've mentioned the hemodynamics or quite extensive list of wish for a patient with a longer life expectancy. What is the main risk for this patient, according to your practice? Is it hemodynamics? Is it more the coronary arteries?
Yeah, it's both.
Both combined?
It's both. But in a young patient, we should not occlude the coronaries first, and hemodynamics should also be okay.
And would everybody protect the coronary with this type of anatomy, or any opinions on that?
I mean, I didn't see like the further measurements of the like VTC and so on. Probably with this type of device, I can like I try to imagine it like that you, if you implant it the way you want to implant it, that with the upper crown, you probably push the left cusp a little bit towards like downwards, and then you prevent, actually, you may prevent coronary obstruction. I'm not sure whether this is true, but this is at least what I'm thinking of this device in terms of coronary.
So we're going to see in the case, but it means that one step of the procedure should, apart from assessing the depth, should be having a close look at the relationship of the left leaflet with the upper crown to make sure that you are just lying on top of the leaflet.
I think also when choosing a device for an anatomy like this, you should factor in coronary protection or not. If you need to treat, probably maybe no one is going to treat such a small anatomy with a balloon expandable device, but in that case, the risk for coronary occlusion in this anatomy is really high, whereas it's not as high if you choose an accurate neo device. Might be higher also with some other self-expanding devices. So in order to have a simplified procedure and a safer procedure for your patient, you should include this factor in device choice.
I mean, you talked about coronary access, and I mean, this device, obviously, the Accurate has the advantage of you can align it. It's like actually, it's a short frame device because, I mean, like
stabilization out is wide open.
Yes, there's like a very, very small metal to artery ratio. So, but what we learned, I think, and there are a couple of nice bench studies on that, is what Didier mentioned, is that the position of the upper crown is actually maybe the only thing that if you get this wrong, then you can have problems with coronary access. Right?
All right.
Okay, so let's see the outcome of the case.
So as you've seen, this patient's got a very small annulus, small anatomy in general, so we'll be implanting an accurate neo2 valve. The pathway for this, of course, is to pre-dilate with a balloon aortic valvuloplasty, and that's the stage that we're at now. It's worth bearing in mind that we've chosen our LV wire with thought. So we've chosen an extra small safari to sit nicely in the apex in this type of anatomy. And we can already see that the wire is in a nice position, which means it's fallen into the commissure, and it's really tracking the outer wall of the aorta. Remember, this valve deploys from the non-coronary cusp outwards, so that's left to right on your screen. So this is a favorable position. So the valve is prepped, and that means that we're ready to do our balloon aortic valvuloplasty. So Rajesh is going to kindly put this on. We'll be using a 20 millimeter balloon. So when we do pace, we tend to pace at 200 here, just to really sort of flatten the aortic pressure and prevent the balloon from popping up and down. And we're about to cross the annulus here. Just let things settle in case there's any forward motion, which looks reasonable to me. Okay, pacing on, please, Rachel. There we go. Okay. Yeah. That's a nice expansion. And pacing off, thank you, Rachel. So it looked like a nice expansion to me there. Couldn't see any constraints. Just mindful of the ECG, there's no high degree block, which means we can safely bring out this balloon. So if you look at Rajesh's hands here, you'll see that the first step of commissural alignment is to have that pin there facing down at the floor, which we call 6 o'clock. And in the vast majority of patients, that will actually get you commissurally aligned up at the annulus level. But of course, we'll check that. So Rajesh, are you happy for me to start inserting? Great. So again, another check of the wire. It's in a very nice position, by which I mean it's dropped into that commissure and it's hugging the outer wall. Slight resistance as you push through the eye sleeve, but really it's a very, very, very lubricious and flexible system. Gentle forward pressure here, nothing like you might experience with some of the other valves. And this should track very nicely around the arch, but if possible, can we just drop the magnification and see this coming round? So you'd feel free to shift the table so we can watch this. So this is very small anatomy, as you know, and it looks like a very large prosthesis, but really we wouldn't have any concerns that this would not track, and as you can see, it is nicely tracking. So we're going to bring this down, and we're going to begin this second stage of commissural alignment. I tend to start about here, but what we're going to do is look at the cobs. And what we see here are those 3 cobs at the top. Now, it's slightly subtle, but to my eye, there's 2 cobs on the left, slightly closer together than the final third cob. So we would call this a 2-to-1 configuration. And what that tells me is that I need to perform some clockwise rotation of the whole prosthesis. So if we could now unmag, please, Matt, so we can see the wire in the LV. And I'm just going to gently rotate this whole prosthesis en bloc, and you can see it's starting to respond. Nothing too aggressive. And the reason I start slightly higher is also you can transmit that torque by pushing down, as I've just done there. So I think that's now a bit more what we call 1-1-1. And to confirm that, I'm now going to come to view 2, which is the 2 cuff overlap. Center up that image. That's a really nice image, because what you'll see, and I'll just take an acquisition here, is you'll see that you've actually got those 3 cobs is the first thing we're looking at, and then we've now got a 2-to-1 configuration. But the really important thing we see here is the free cell, which is pointing to the right of the image, and that tells us that we have achieved commissural alignment, perhaps slight room for improvement, just increasing it ever so slightly. So you see that free cell out towards the right. That's the easiest way to determine whether you're commissurally aligned. So let's go back to our implant view, which is view 1. And we're going to get our mind in gear about now implanting this valve. So the general rule with this valve is to make sure that you have enough forward pressure throughout all stages of deployment. And we know that this patient's anatomy has a tapered left ventricular outflow tract, so that's probably even more important in this particular patient, to ensure that you have a constant forward pressure. So we're happy with our wire position, and I'm just on mag is on 22, and I'm just going to slowly descend towards the annulus. And this is nice and slow at this stage. There's no quick movements really. And you'll see the central marker. That will be what we're planning to implant at the annulus. And that will get us at the target depth which we want. Pigtail is nicely in that cusp of the guide.
Yeah.
Keeping the mind on pressures.
You don't like it.
No.
Here's a test for me, please, Rajesh. A little bit of a way to go, but again, not rushing things. Looking pretty good there. So we'll take a picture here, Rajesh. It looks pretty good. Got some AR there, but we're aiming for a lowish deployment here because of the lower left main. So I'm happy for you to start one. If you need to, you can always work the wire with your other hand. Bit of a test for me, Rajesh. I think we slightly topped up there. No, not too bad. I'm going to give a bit more forwards. Also looking to see those stabilization arches come out. This is nice and slow, as you can see what we're doing here. Okay, the arches are out. And then we'll take a picture when we get to the end of one, which is the... Okay, so let's have a picture there, please. I've got constant forward pressure on this. Looks good to me. So remember to bring back the pigtail, particularly in this small type of anatomy. Make sure it doesn't catch at the top. So it's slightly caught there, so I won't do any further. So on to you, Rajesh, for the second stage. Yeah. Good. Okay, and save that image for me. So what we saw then is everything moved forward, which is what we want. And we've just been reassuring the patient. Everything looks good my end. Good. So the next thing now is to remove this. So Rajesh is bringing that wire back in. And what that does is it brings you away from that outer wall, and make sure that we don't catch anything with the nose cone. Yes, please. And he's now going to extrude the wire. There we go. That brought us away. Keeping attention now as I pass through the valve. Again, this is not something to do quickly. There we are. We're coming back into the descending now. This is a two-stage closure, so we can do this, recapture it on blind. So you're basically just reversing the steps. So step 2 is what we do as the first stage here, and then Rajesh is now going to do what we call a soft kiss. Like so. So our mean gradient at the start of this case we think is about 60, don't we? So we'll see what improvement we've made upon that. Okay, there we go. So that's looking good, and you can see there's no gradient there on flushing of those lines, which of course is a very satisfactory result. It's a very nice result. We've got excellent filling of the coronaries there. We've got a nice low deployment without any trade-off in terms of pacing, and really, to my eye, no significant aortic regurgitation, nice and coaxial. Yeah, let's do view 2 as well, please. And then what we'll use this for is modelling, which we can talk about in the discussion. And this will tell us about our future revalving options for this patient. Yeah, so I think in summary, we've chosen the right valve for this type of anatomy here. Very, very small annulus, even smaller LVOT. We've managed to achieve commissural alignment and target deployment depth, which has meant we haven't had to protect that left main stem. And also we've confirmed an excellent hemodynamic result here without any aortic regurgitation.
Thank you very much, Chris, for sharing this case with us. One of the beauty of this device is the ability to achieve a commissural alignment. So would you once again explain the key steps, position of the handle at the start, which projection you check for the first assessment of the commissural alignment, and how do you manage across the aortic annulus?
Sure. So first and foremost, if you haven't done it with this valve, it is not as complex as it sounds. And I think the simplest way to think of it is a 3-step process. The first step is incredibly easy, which is to make sure that the valve is handed to you and loaded on the wire with the safety pin down at 6 o'clock. That is step 1. And actually, in the vast majority of patients, we know that this, even passively, will mean that you're commissurally aligned when you come to the annulus. That's step 1. The valve, as you can see, delivers round, and then you need to get your mind in gear for step 2, which is in the coplanar three-cuff view, what you're looking at are what we call the cobs, which you saw in that video are at the top of the valve, which are essentially the commissures of the THV. And what you're looking for is their relationship to one another. And these can come in three configurations. It can be 1, 1, 1, and what that means is that they're all equally spaced apart like this. Or, as we did in this case, you can have these first two slightly closer together, and that would be a 2, 1 configuration. And then logically, it means the only other option is like this, where the first one is further away from the other two, and that's a 1 plus 2. And then with that information, it's very, very useful. If you have a 2 plus 1, then it means you have to give clockwise rotation, Didier, to the whole device, and you'll actually be able to see it start moving around, even in that three-cuff view. If it's the opposite, which is 1, 2, then you're going to want to bring that device anti-clockwise. The only complex thing I would say is if you end up with 1, 1, 1, and you're either perfectly aligned or completely misaligned. Now, usually you're perfectly aligned, but this brings us to the third confirmatory step, which is to swing that camera over into your cusp overlay view. And what you're looking for really is that free cell, and it's pointing out to the right of your screen. I think that is the simplest way of confirming in 3 steps whether you're commissary aligned with this, with the accurate Neo2.
Thank you, Chris. And we've seen the rotation that you apply to the handle to get that commissure alignment, and it's the response is really, really nice. It's quite impressive. At the end, you release the tension before deploying the device, otherwise you're going to accumulate a lot of tension within the system that may change at the end the commercial alignment. So is it something that you do?
Yeah, very much so. And as I say, I start, I think, probably slightly higher than most, because actually part of that releasing the tension is in that process going down to the annulus. You allow more of that torque to transmit and make sure that you're not storing anything up, as you say, for that final moment of release, which could lead to unpredictability.
But do you see any changes in the way you have aligned the commissures after you go down into the annular plane?
Yeah, I think you're right. I think you do get some additional rotation as you descend down into the annulus. The other concept about why I do it slightly high, and I'm not sure it's necessarily the right thing to do, is just the idea of, in more calcific anatomy particularly, rotating en bloc when you're sort of fully across that valve and in between the leaflets. But I know that actually a few operators start lower down and actually rotate there to get fully precise results as well.
Maybe a couple of further questions regarding the technique. So you pre-dilated despite the fact that it was not heavily calcified. So maybe you comment on that and your choice of wire. So I think it was a Safari XS.
Yeah, that's right.
XS,
yeah, so I think pre-dilatation with this valve, to me, I think you get the best results from it when you do a mandatory BAV. I think it prepares the valve, and actually what really happens is it means your post-dilatation rates are much smaller, single digits for us. And the sizing matrix for how you decide your pre-dilatation is that we tend to use the perimeter derived, divide it by pi and -1, and that gives us, for this particular case, a 20 balloon. The second point around wire choice, I think probably about 70% of cases will be a Safari small. But in that pre-procedural echo, I think that's useful information, and we should look at it. And this particular anatomy was a very small cavity. So I think this valve does like to have a nice stable rail on that outer curve, and with the wire nicely in the apex. So for this patient, I think extra small was the better choice.
Right.
Okay, so guys, we've seen that we can achieve with this type of device, so hemodynamically speaking, very great outcomes, no PV leak, because we've seen that, and we all agreed upon the fact that PV leak is not really an issue now nowadays with the new generation TAVI devices. So we can expect with the commissural alignment a nice outcome at the index procedure. Then comes the redo TAVI. So we've seen through your case, Federico, that you decided to more or less go for an inflow-to-inflow expansion of the short stand frame balloon expandable platform. and the trade-off is the leaflet overhang. So what would be your advice in terms of anticipating the position of the second TAVI for the redo TAVI? Would you advocate to go a little bit higher, or would you remain really at the bottom part of the accurate device?
I think a lot depends on the mechanism of failure, the mode of failure of the index TAVI device. Mostly TAVI appear to fail by regurgitation. And so in this case, you can implant, a short frame device at the inflow of the accurate new device that you implanted in the case. If the mode of failure is stenosis, we might want to do some more considerations on how to actually treat that case, and it really depends on a new CT scan and on seeing the relationship between the leaflets and the anatomy at a further time point.
And Julia, so you mentioned for the risk of preventing the risk of stroke for the patient cerebral protection device, that is an adjunct to the TAVI procedure. If we think about the redo TAVI, do you think that as an adjunctive therapy, those leaflet modification techniques could be useful, particularly with a supraannular functioning device like that? Would devices like the shortcut or basilica-derived therapies, do you think that it's going to take is going to be part of the procedure in the future? Do you believe in these therapies?
Well, yes.
So it's yes, okay.
To some extent, but to avoid them is better. If we think ahead and we manage to choose a prosthesis where we don't need it in the future, then it might be better. We don't know yet. And we have very many new devices that are coming to the market. Probably they will solve all our problems, but we don't know. Probably we will have much more problems then.
So time will tell.
Chris, there are some ways to try and anticipate this, like from a simulating perspective. You want to show us some of these?
Yeah, I'd love to. Okay, bear with me. Okay, so I've prepared a couple of slides here, and what you saw earlier on in the case.
Can we see the smart screen on the main screen, please? Thank you.
Excellent, thanks so much. So look, there's a lot going on in this slide, but let's break it down. And essentially, remember our strategy was that we were going to go in intentionally at 5 to 7 millimeters with this valve prosthesis. And what that actually does is that it almost minuses the height of the wrist plane of the valve. So that's one of the key procedural understandings that we have to get when we're thinking about implanting an accurate Neo2. And what the kind folk at Boston did was that they went on and actually did virtually implant a sapien within this. And what you can see, despite this lady's tiny, tiny anatomy, that you're able to really intubate both coronaries here. And there's been some good work done by Arif Koka, which shows that if you take an oversized JL and you sort of allow it to hug the inner aspect of the aorta, you can then pop into that left coronary sinus with ease. But of course, Mohammed, these are computer simulations, which we always have a degree of skepticism about. So actually what we went on and did further for this particular patient is to look at the angiograms that we achieved at the end of the case and with 3D modeling. And what you can see if we address first is the concept of coronary reaccess, which is supported by the borescope imaging. And you see, due to the design of the accurate, with these open cells at the top, that we're really able to intubate these coronaries without any significant difficulty on the in vitro model. And if we take that one step further, and again, you'll see, I'll just highlight here again, they've put a balloon expandable valve in within. What you see here is you've got your opening of your accurate, and then what we have inside of that is your balloon expandable here. And they've been lined up together like so. And again, what you see nicely is the ability to access these coronaries. So this is a revalving in a very, very small anatomy. And perhaps the final concluding concept that I wanted to get across, which is that this still provides some anxiety, this degree of VTC. But what I've realized is that this is a two-dimensional way of thinking, and London Valves is all about expanding into the three-dimensional realm. And so what we're seeing here is a two-dimensional representation of what is actually a three-dimensional shape, which actually has an area to it. So this is a bit like a crescent. And so we need to get our minds in gear when we're thinking about revalving, that we're no longer working in the two-dimensional space. And fluoroscopy can trick us with that. And actually, with the Accurate Neo2, with the balloon expandable platform on the inside, we actually begin to introduce this concept of the crescent. And I guess the analogy would be a little bit like left ventricular outflow tract obstruction with TAVI and mitral.
Thank you very much, Chris. So we are coming to the end of the session. So we had a couple of objectives at the start of the session. So we hope that at the end of this session, you've understood how important could be valve selection in preventing some very important complications at the index procedure. How important is the valve design to make sure that we can tackle the issue of longer life expectancy of younger patients. And we also had a very nice lecture on the data related to the Accurate Neo2 device that are extremely promising, particularly with the low pacemaker rate and the very nice hemodynamics. And we've seen how the computerized simulation could help us decide on the appropriate technique and the redo procedure for our patients. So I would like to thank you first, for attending the session so late in the day. Thank all my friends for such a beautiful discussion, and it's now time to have a drink, and we'll see you tomorrow.